Worked up this case for a friend who reached out to me and asked me to take a look at this for one of his patients. You can see there's a lot of bone loss in the posterior mandible. And what makes this even more complicated is you can see there's a very thin maxilla. Even if you turn up the Hounsfield units, you can still see lots of deficiencies. One that's to remark is the bony deficiency here in the mandibular anterior. That's going to really complicate placement the day of surgery. And you can also see up here this periapical pathology that's caused some bone loss around this premolar, caused a lot of difficulties too. So out of all the things, that was the most difficult things to work around. This is not the ideal location where I want to place implants, but given the issues that we're seeing on these implants, as far as bone loss, this is the most ideal situation where we can put these implants. So getting it the biggest AP spread we can in the mandibular anterior area as close as possible to the nerves without infringing on the nerves. These are the two ideal locations, staying away from this infection. So I think the best ideal scenario would be to remove these teeth, degranulate this cyst, lay a large flap, place a bone pilodral guide, place our 4 implants, graft this defect here at the same time you place PRF membranes, suture everything closed, and be done with the mandible. If you look in cross-section in the posterior quadrants, we do have some height, not a lot of height. If you measure this, it is approximately 6.6 millimeters. We could do something off angle back here, place a 6.0 implant, make it a little bit further, get some posterior bone support. That's not an option, or that's not off the table. It could definitely be an option if that's what you wanted to do. But the problem is on the left side, I didn't see as much bone. And over here we are at 5.5, which makes it much more difficult to place implants in this posterior region. So my focus was to get at a minimum 4 implants in the mandibular anterior region. I think it's doable. I think if you had any complications, you could just abort, graft it, put them in a denture, let him heal, get this bony abnormality to resolve, and then come back and place 4 implants after he's healed in a complete denture. Not ideal, but you could do that. And if you did do that, then you could place 4 after waiting 3 to 4 months, place 4 and immediate load the lower arch. On the upper arch, that upper arch is different. My initial thought was to let's get out of this. My initial thought was to place implants in the canine, and both these look really good in cross section. Keeping a really good angle so that you have as much optimal parallelism as possible with the denture, and not angling this implant out to the facial. Here and here for the canines, I just picked an arbitrary size. I think this is a 4.3 by 10, and then in the back, I was looking at placing an implant here in this premolar region. And if you do, I'll show you what that looks like. Let's see, click on maxillary. Let's see, 4.3 by 8. It'd be somewhere around here would be the proper implant placement. You could do a little sinus bump if you want to. And if you look at that in this panoramic view, you can see that this implant is sticking out much further than these implants here. So I decided to not place an implant in this premolar region. The other reason why is when I looked at this in cross-section, we really had no bone to place an implant. Let's just see what that looks like. Even if I just added one in there, you would have to do an internal sinus lift. And if you did, then we were too high. So I felt like those areas weren't sufficient to place implants. And maybe we should, I don't want to do that. Back up. This implant as well needed to be let out. So where does that leave us? So I like that. I like the canine sites this is essentially the first molar region. How many millimeters of bone does he have? Not much. If I measure it, it is approximately 5 millimeters. Not bad. Could do an internal sinus lift, immediate implant placement. Let's blow this up. Let's see. Click off that. Blow this up. And in this area here, I'm going to measure this bone. and we have approximately 4.8 millimeters. So not bad. I think internal sinus lifts in both of these regions would be perfect for this patient. Let's click this off. And then, so internal sinus lift. Let's get all my implants up. So internal sinus lift, very doable. Immediate placement up here. I think immediate placement in upper would be great. What's in PRF sinus lifts? I think you could swing the immediate placement in the lower. If it got too bizarre, then I think just grafting it, put a denture on the bottom would be adequate. And if you did in 3 to 4 months after the upper's healed, if you just grafted the lower, then at that time you could convert the upper to implant supported semi-precision attachments or zest attachments, and on the lower you could screw retain this and make this fixed. I think going fixed on the bottom and an upper implant supported overdenture would be adequate for this case. Later on, I think immediate placement in the anterior maxilla is going to be a must. I'm afraid that if you extract this tooth and you have bone dieback, you're going to be much more compromised in the maxilla. So I would really shoot for placing implants in the maxilla. Let's replace this with a 10 millimeter implant. So I'm thinking 4.3s for all four in the maxilla, 8s in the posterior, 10s in the anterior, and all down here. These are all 3.5 by 13 millimeter Blueskybio Biomax. And that's pretty much it. All right. Give me some feedback. Let me know what you think.